Okay, so a few specifics on treating depression in the elderly. Anergic depressions, just like we talked about with major depression in younger people, Wellbutrin is a good drug to use. In particular, it's because it has very few cardiac side effects, and there are a number of people that have some cardiac conditions. Okay, look at this. Study, 350 people, major depression, 86% had at least a response, which is 50% decrease in symptoms, so it's well tolerated, has the lowest side effect profile of all the antidepressants. So there's reasons for doing that. This is becoming a very popular combination here. We kind of jokingly call it R&R, Ritalin and Remeron. Now, Remeron is what my mother ended up taking. At low doses, it has a lot of sedation, okay? And people who are having depressions, if they're having trouble going to sleep, on lower doses of Remeron, it can actually help them go to sleep. So it can be used as a sleeping pill. Now, if you don't want to treat depression, but you just want to treat sleep problem, insomnia, initial insomnia, the dose is 7.5 milligrams. And that'll knock you on your butt, but it does not cause orthostatic hypotension. So if she has to wake up, she's not going to get dizzy and all that kind of stuff, okay? Secondly is that, and this is much more characteristic of depression in the elderly, is weight loss, is failure to thrive. And Remeron is an antidepressant that is notorious for putting weight on, okay? So for a person who's dropping weight like crazy, a drug that treats depression, may help sleep, and also helps them gain weight is good. But because of some sedation problems, they may wake up in the morning and they feel low energy and that kind of stuff. What's very well tolerated, especially with these anergic depressions where they can't get off the couch kind of thing, is a tiny dose of stimulant. It doesn't have to be Ritalin, it could be Adderall, but like 5 milligrams. Very well tolerated. Agitated depressions. First, rule out delirium and mania. If the person has a history of bipolar, you never develop bipolar disease in your 60s. There will be a history of this. But look for that. And then Remeron, again, seems to be a very good choice. If you use SSRIs, you've got to oftentimes put in a little tiny dose of benzodiazepine up front to kind of reduce some of the agitation, but you don't want to leave it on board very long. Maybe 3 weeks like we've talked about before, and then get that out of there because that can be problematic with older people. Psychotic depressions are more common in elders than they are in adults. And I had this lady who actually I treated her husband, but she came in with him often, but she was in and out of her own depressions, and she was probably, I don't know, she was probably 75 years old or a little bit older than that maybe. And she would come in with him, and he would talk about her problems. And I wasn't treating her, but I frequently said, would you please call up your psychiatrist and talk to him? But she had this, every time she got more severely depressed, she developed delusion. And her delusion was that she didn't have any legs. And I don't think I've mentioned this case to you, have I? Okay, and so she came in, and he said, well, she doesn't think she has any legs. And I said, okay, this is so-and-so. I understand. What are these? And I pointed to her legs. I don't know. Somebody put something there, but they're not my legs. Okay, all right. You know, give her upper antidepressant, give her a little antipsychotic. 3 weeks later, they're back. Okay. I want to tell you this one little story about this. God, this lady, this poor woman. She came in to see me, and she had depression, but she had psychotic features, but she had no history of psychosis, but she had late life depression. And so she came in, and her delusion was, she's so worried about this. Her husband's saying, oh, Dr. Preston, something wrong with my wife. She's hiding in the closet, you know, and under the kitchen table all day and stuff like this. And I'd say, what's the matter? And she goes, they're going to arrest me and throw me in jail. And I said, well, why do you think that? She says, and she'd hear a siren or something, you know, and she'd go hide in the closet for several hours, wouldn't come out. And she said that she had worked for the school system for many, many years, and she retired maybe like 20 years ago. And when she left the school, she packed up all her belongings and everything. She stole a pencil from the school, okay? And she was convinced that they were going to come and track her down and arrest her for being a thief. Now, I must tell you, I was convinced to say to her, just give the pencil back. No. So anyhow, but she responded very well to antidepressants with antipsychotics, and so I was working at Kaiser, and so at some point I've seen her like every 3 months or something because she's just doing fine. She calls me up, and one day and she says, "Dr. Preston, this is whatever her name was." Yes, ma'am. How are you doing? Well, the police are after me again. I said, have you, by any chance, stopped taking your medicine? Well, yes. Okay. God. Anyway, with psychotic depressions, remember what you got to do? You got to add antipsychotics, right? Okay. But be careful about Wellbutrin, because Wellbutrin increases what? Dopamine. That's the problem with psychosis, too much dopamine, right? So you don't want to use Wellbutrin. And elders really respond well to ECT. Sometimes when they can't, they can't tolerate the medications, ECT is very effective for them.